Welcome to Early Matters, the podcast on the science and policy of early childhood, hosted by Dr. Catherine B. Stevens. Early Matters features in-depth conversations with leading researchers, practitioners, and policy experts on what matters most for young children and their families to thrive.
Welcome to Early Matters. I'm delighted to introduce today's guest, Dr. Cynthia Osborne, who is a professor at Vanderbilt University's Peabody College of Education and Human Development and a nationally renowned researcher and expert on child and family policy. She's also the founder and executive director of the Prenatal-to-3 Policy Impact Center based at Vanderbilt, which is an academic research center that focuses on building the evidence base on the most effective state policies to improve the well-being of young children and their families. The center has just released their 2023 Prenatal-to-3 State Policy Roadmap, which I'm really excited to hear more about. The roadmap lays out the most recent research on the best public investments states can make to impact child outcomes and shows where each state is on the most effective policies and strategies. Cynthia, welcome to Early Matters.
Well, thank you so much for having me today. I really appreciate the opportunity to speak with you.
So to start with, can you just explain more about what the Prenatal-to-3 Policy Impact Center is and why does it focus specifically on the prenatal-to-3 period?
Well, we're a research center, like you said, at Vanderbilt University, and our whole purpose is to really understand what the most effective policies are that states can implement in order to create the conditions in which children will thrive from the start. So the science of the developing child has been really clear for the past several decades about the importance of the earliest years in terms of shaping both brain and healthy body development. And we know that children who are raised in safe, stable, nurturing environments with limited exposure to adversity in these earliest years, that really sets them on a trajectory for lifelong health and well-being. So if we can get it right then, if we can get them off to a healthy start, that it really makes a difference throughout their life course.
So the center's identified what it describes as key universal objectives that help ensure that young children and their families can thrive. And I'd love to hear more about what they are and how you identified them.
Well, we took all of the science of the developing child and tried to operationalize that into what we call these 8 Prenatal-to-3 policy goals. Again, these are the conditions that if we could meet these conditions, we know that this will lead to better school readiness, better long-term health, fewer incidents of child maltreatment, and so forth. And so what these policy goals include is making sure that families have access to the services that they're eligible for, making it so that parents can both work and care for their children, that within households there's sufficient resources, including food security, economic security, housing stability, that our babies are born healthy to healthy parents, taking into consideration both their physical and mental health, and that our parents have the knowledge of their children's development and the skills to really engage in these nurturing relationships that we know are so important for healthy brain and body development. And when children are not with their families, that they're also in these nurturing relationships, and that we can identify any developmental delays that children are having as early as possible and make it so that they get the services that they need to get them back on track for optimal development. So those are what we're striving for and that we are absolutely not neutral to. We know the science is clear that these are important. But what we did was say, well, what are the most effective policies that will create those conditions? And for that, we came with a blank slate to try to understand what the evidence would tell us.
So when you say what the evidence will tell us, I want to hear more about the specific policy goals, but as sort of context for that, when you say what the evidence will tell us, what evidence are you talking about? And how do you look at that? How do you decide between good and bad evidence or adequate, inadequate evidence? Can you just say more about that whole process?
Absolutely. This was definitely something that we invested a lot of time in as we were getting started. So we started just by literally listing as many state level policies and programs that could be thought of as going statewide as we possibly could. We talked with everyone to figure out, what are the policies that are out there?
What are a few examples of the kinds of things?
Everything from expanding Medicaid and a state earned income tax credit to statewide implementation of home visiting programs or early intervention programs. A lot of people were interested in the adequate childcare ratios or childcare teacher compensation, kind of everything that folks were actually trying to implement to support children and their parents.
Just to clarify this, to make sure that the audience understands. So it sounds like your list, you're kind of identifying all the possible policies that might improve the well-being of children and families. So is that what you're saying? In other words, the listing part was just the starting place, saying these are all policies that could reasonably improve outcomes. Is that right?
That's right. It was the universe of what was possible. And from there, we said, well, is there a strong theory of change here? Is it plausible that this would have an impact on infants and toddlers or the parents of infants and toddlers? And then, is there any research on this? So we reviewed all of the peer-reviewed literature, all the gray literature out of the best kind of research centers, to see, has anything actually been said, evaluated about these policies? And we started there for each of them. And there were about 24 that we could say something meaningful about, that there had actually been research conducted on them that we could make some assessment about. And then we had a criteria for that research in terms of whether it was rigorous or not. We wanted to ensure that we were looking at the studies that attempted to draw a causal link between an implementation of that policy and outcomes related to our 8 policy goals. And that whittled down the studies even further, right? Because there are a lot of studies that have been done, but they have problems with regard to selection bias or other things that make it so that we can see there might be a correlation between that policy and particular outcomes, but we can't really say with enough certainty that there was a causal link. So we further wanted to kind of strengthen our criteria for what was evidence and said that for any policy for us to really consider that it actually would be effective, is that that policy had to be studied in more than one state context. So we couldn't just look at one state, and by more than one either author or analysis of a different sample. So we couldn't just take one time that it had been done and say, well, okay, this worked, this one pilot, and we're going to say that this goes on our list. We wanted to see that it had been generalized in some way to a different context. So we set the bar pretty high from the start so that we could say with as much confidence as possible that the evidence supports that these will have a causal impact.
So you started with this list of the whole universe of possible policies, and then reviewed the evidence that would be relevant to this whole universe, which that must have, just as kind of a side note, how long did that take? That sounds very labor intensive. That seems like a very big project.
It was a very big project. I have amazing team members, and we did a lot of these initial reviews within a couple of months. And you can tell pretty quickly whether there's anything to say about a policy or not, and whether the evidence is rigorous. Once we got it down to our 24 policies that we felt that we could really say something about, then we spent a lot of time digging into each of those studies that had been done and carefully scrutinizing whether it met our threshold for being rigorous enough, whether the kind of study actually spoke to our population, our age group, Then we went through each outcome that it analyzed and indicated whether it had a positive impact, null impact, or detrimental impact for each study, for each outcome. And these are all in our clearinghouse. We have about 24 comprehensive evidence reviews where we go through what the policy is, what the theory of change is, what each of the studies that has looked at this causal impacts, what the evidence says there, and what our conclusions are based on that. But there wasn't any guide to just say, well, now this is effective or this isn't effective. We are looking to see whether it impacts at least one of our 8 policy goals. But you have some researchers who will look in one paper at 20 different outcomes. So you'll get 18 null impacts and 2 positive impacts. And that isn't really something to say that this policy doesn't work. It's to really scrutinize, well, let's see, was the theory strong for all of them? Could we really answer for each of these outcomes? Are they basically 5 different ways of saying the same outcome? So we had to use a lot of our judgment as to the strength of the study, the size of the sample, the age of the study, what it was trying to take into consideration. And there weren't enough studies to be able to do a meta-analysis for each of these policies. That's a pretty rigorous statistical approach that says, let's look at the effect sizes for every study that's been done on this one outcome, and we can tell you overall, on average, if it works. These weren't set up to do that. So we used as conservative an approach as possible to say that we say overall the evidence is leaning positive here, or it's null. There's very few that have detrimental effects. And we wanted to be as careful to say that something's not effective as we are in saying that something is effective. As you know, something may actually work in a different context, but it just hasn't. The effects right now are just null, that we don't have enough evidence. We need it to be studied more rigorously. We need more studies on it and so forth. But that was our approach to determining whether we could say that a policy actually, quote unquote, works.
So you've mentioned a couple of things that sound like sort of cornerstones of the rigorous approach that you've taken. And in case people in our audience aren't researchers or aren't as familiar with research, I wanted to ask you a little bit more about them. First of all, when you say theory of change and that you want to see that for a particular intervention or particular policy, there's a theory of change, what do you mean by that?
Well, for non-researchers, they usually just think of this as kind of the duh test. Should we expect that this policy should have an impact on infants and toddlers? But we, in research, really want to lay that out. It's our hypotheses of why is it that changing this policy, increasing a minimum wage, should impact birth outcomes? Why would we expect that home visiting programs should impact parenting outcomes? And some are very obvious, and sometimes you have to figure out, well, what are you really trying to hypothesize there?
So to take the minimum wage one, just as a concrete example, so let's just say there's a theory that increasing minimum wage would impact birth outcomes. What would be the theory of change that would lead you to think that actually might make sense?
So the increase in a minimum wage, the research is pretty clear that it does increase wages among folks who are the lowest wage workers or the least educated workers. And that there's also strong research to suggest that money is linked to stress, and stress is linked to birth outcomes. And so the theory is that if you have, in this case, women who would be working in very low wage sort of jobs, that in states that have increased the minimum wage, that they should have slightly higher levels of income, that probably the mechanism, therefore, is that it reduces their stress, allows them to purchase the things that they need, food, shelter, transportation to the doctor, whatever it might be, to have a healthier pregnancy. And in fact, the research is clear that higher minimum wages are linked to better birth outcomes. We can't actually test the mechanism because we're not creating an experiment on that of what the actual mechanism is. But that's our hypothesis of kind of the dominoes that fall in order to lead from a policy change to an actual outcome.
So a person could say, given what we know about child development, given what we know about prenatal health, that reducing stress that is associated with being very poor, it makes sense that it could help.
That's right. That's right. There were some things that we were trying to figure out, how does that theory of change actually work? So I'll give you an example where there's research that says a state earned income tax credit, which works the same way that a federal earned income tax credit does. It usually takes a percentage of the federal credit and gives that to folks who file their state taxes.
So that means basically you're taking low income wage earners and just raising the amount of money they get, a little bit like the minimum wage, actually. Is that right?
Yes, except that the tax credit, the earned income tax credit, comes once a year, and it comes when you file your taxes. And a lot of people will, if they know you're getting a refund, will file it in January. And the maximum of the federal credit when you have 2 kids is around $6,000. And so a state credit is usually around 10% of that credit. So that's another $600 or so. Percentage ranges across the country. But the research says 10% is really where you start to see the impacts on family well-being. Well, it makes a lot of sense that you would see increases in employment. I'm going to get more if I work more. The federal EITC works that way. And money leads to a lot of positive things for families, reduced food insecurity, increased housing and stability, and so forth. But there's a study that looks at the effect of earned income tax credit on birth outcomes. Well, if they're looking at child well-being among an existing child, that makes a lot of sense. But how can money that you're going to get in the future improve your birth outcomes before that baby has been born, right? It's hard to really kind of understand where that theory of change lines up and what that hypothesis looks like. So there were things like that we needed to sort out and say, well, is that an outcome that we can really pay attention to or understand, or that makes sense to help us really think about how this policy is going to impact these outcomes? We got down to that level of minutia in each of these.
So another term you used in terms of distinguishing between stronger and weaker research or evidence was selection bias. Can you say something about what that is and what the problem is with studies that might have that?
Well, so selection bias as a researcher is a thing that we try to avoid at all costs, because it is what we often attribute to, say, a policy or a program or something, what is actually not about the policy, but about the people who are using that program or taking that policy up. That it's really the characteristics of those folks who are using that program that are either perhaps better already, meaning that they are more likely to have the skills to be employed, or they're healthier to begin with, and that we don't take into consideration the characteristics of the folks who would be using this. And then we attribute better outcomes to the policy or program rather than those characteristics themselves. A lot of the research that I've done over my career has been on the impact of marriage on children's outcomes. So the fact that the research is overwhelmingly clear that children who are born and raised in married parent households have better outcomes on everything that we have ever measured. It is the most robust finding that is out there. However, what we also know about marriage is that the people who are getting married today have higher levels of education. They have the ability to be in healthier relationships. They have better mental health, better physical health. They have higher earnings. They're telling us they got their ducks in a row and then they got married. It wouldn't be realistic to assume that if we just got any 2 people married, that their kids would be better off. It's the characteristics of the people who are getting married that lead to these benefits for kids, or at least most of it. I'm not saying that marriage doesn't matter. I'm married and it matters a lot for me. But the reason that my kids are healthy and doing well probably isn't just because I'm married, but because of what I was able to bring to the marriage before I even got there.
And just on that topic, I just did a podcast with Brad Wilcox, who has done a lot of work on this, and Melissa Kearney. He's coming out with a new book on this. I think it also just stands to reason that, number one, this is a bit of a detour, but that a two-parent family is more likely to have more financial resources. But it also seems likely that a two-parent family has more human resources, right? Just the fact that there's two people carrying
4 eyes, 4 arms,
exactly,
4 ears. All of those things make a big difference when you're dealing with infants and toddlers. And so that sort of support, and that they're there to support each other. If anyone has ever tried to take care of a child by themselves for a very long period of time without anyone else to support that, it can be very exhausting and overwhelming. And so there's no doubt in my mind that it's easier for folks to parent not in isolation, but obviously there's issues with regard to marriage, whether it's a safe marriage, a happy marriage, and whether they're co-parenting well. So there's a larger conversation, obviously, about marriage itself. But I don't think that the idea that 4 arms and 4 eyes and 2 incomes, that those things really matter a lot for kids.
So this is a tangent, but I'm just wondering, has there been any research done? So let's just say you're a single mother, young and low income, and you're raising a baby and a toddler by yourself, which the most stable and resourced person might find that stressful. If that is in fact stressful for that mother, and then she gets pregnant again, is there any research on whether that additional stress is evident in the birth of her second or her third child?
Well, they haven't necessarily done the research that is just limiting it to single parents, but there are studies that do show for sure that high levels of stress, whether it's from trying to parent by yourself or being in a violent relationship or just living in extreme poverty, that those high levels of stress have serious implications for the mother's own physical health and the physical health of the developing fetus, which is why we focus on the prenatal period as well as the first 2 years of life or 3 years of life, because it is so important, the environment in which we are born into and the resources that the mother has available to her prior to our birth have a big impact on that. And so I haven't seen a study that specifically looked at the addition of another child, but any time that you increase stress, you do potential damage to the developing child.
So getting back to more specifics about the work you're engaged in now, the center has just released your annual Prenatal-to-3 State Policy Roadmap for 2023, which lays out the strategies and policies that states can implement to achieve these specific policy goals. So the first question I have is, what is the difference between a policy and a strategy? Could you give some examples of what that is?
Absolutely. And we made up this distinction. Some may say, it's a difference without a distinction, but it is important internally to our group. The evidence for both policies and strategies is equally strong. We use the same rigorous threshold for whether this is something that the research says is effective or not. However, for policies, the research provides some sort of guide as to what states would actually need to do. So, for instance, the overwhelming research on a paid family leave program was conducted on California's program when it was 6 weeks. So our threshold is that your program has to be 6 weeks. We can't say anything about an 8, 10, or 12-week program yet, but we can say something that it needs to be minimum 6 weeks. Similarly, the research on state minimum wages, the bulk of the research suggests that a $10 minimum wage is kind of the threshold to see the impacts that the research says is probable. But the research hasn't looked at $12 and $15 minimum wages yet. So we can't provide guidance above $10, but $10 is the threshold. Well, so by contrast, in home visiting, for instance, these are programs that support expectant parents or new parents as they transition into this really hard role. And it's a professional or paraprofessional that comes into your parents' house and provides this sort of support and connection to resources. The most rigorous research that's been conducted says that on average, these programs are effective at improving parenting outcomes. When we look across a wide range of programs, that's the most robust finding. But there isn't any guidance as to, well, how should states actually implement these? What's the level of funding that's required to do this? We provide some policy guidance, some policy levers, how states are funding this, what they're doing to make it so that more people who are eligible can access it. But we can't say, check, yes, this state is doing home visiting right. And so that's our difference between a policy and a strategy.
I see. So a policy, it sounds like, is more kind of black and white, like is your minimum wage at least $10 or isn't it?
Exactly.
So in this year's roadmap, you identified 4 state policies and 8 state strategies. To start with, what are the 4 policies?
Well, the 4 policies include increasing the income eligibility threshold for health insurance. The most studied way to do that is by a state expanding Medicaid through the Affordable Care Act. Another effective policy is a state implementing a paid family leave program that is at least 6 weeks in length. The other is a state minimum wage that's at least $10 or greater. And the fourth is a state earned income tax credit that is at least 10% of the federal credit and fully refundable. We're not saying that there aren't other things out there that might work, but those are the 4 policies that have evidence of a causal link between a state implementing those policies and actually seeing changes in outcomes at a population level.
So those 4, tell me if I'm getting this right, it sounds like what the evidence is showing they're affecting is health, maternal and child health through expansion of Medicaid, and then the minimum wage and the EITC, as we were talking about a few minutes ago. At the very least, if people are less panicked about not having enough money, at the very least, that reduces their stress.
Yes.
Which I guess at this point, research is pretty clear is enormously important.
Exactly.
And then the paid leave one, I can imagine, as you described it, the theory of change is A, that people are bonding with their babies, or B, it's actually just reducing their stress because going back to work a week or 2 after you've had a baby, I've not done that, but I can imagine that would be very stressful.
Absolutely. The paid family leave program seems to be impacting more of our policy goals than any other policy or strategy on the roadmap, meaning that it not only allows more families to access leave following the birth of a child, they do things like visit their doctor at 6 weeks, take their child to their well visits, get their children their immunizations on time, get their children their developmental screenings. They also do things like read with their child and spend more time with their child and engage in these nurturing relationships with their child. So that bonding that you talked about. But there's something in this policy for everyone. It's one of the most pro-work policies that we've identified on the roadmap, meaning that women who have a child are much more likely to return to their pre-birth employment in states that have a paid family leave program, which is really good for employers because we know how expensive it is to find and hire and train a person to replace anyone. And it leads to higher levels of household resources, increased spending. which is really good for both the family itself as well as the overall economy. So this is a program that really seems to have an important impact on our families in the earliest years of their children's development.
Mm-hmm. And are you talking primarily about lower income women? Is that what the research you're referring to?
Actually, the research here is across the board. Now, the folks who are more likely to be impacted by a state paid family leave program are families with lower levels of income. Because, as you know, currently we have no federal paid leave, but we have a federal unpaid leave program. And it's very hard to take 12 weeks off of work unpaid for anyone, but especially folks with lower levels of income who may not have been able to put away savings and so forth. So it's lower income folks who are more likely to return to work 2 weeks, 3 weeks after having a baby. So this paid leave does make it so that they're more likely to be able to stay with their children for longer than they would. They're also less likely to work in jobs that have already offered a paid leave program. So for higher income employees, they often have that as part of a benefits package of some number of weeks that are offered. So although it extends access to families at the lower levels of income, the benefits seem to be kind of across the board. So this is something that really makes a difference for all families to be able to have the opportunity in those first several months after a child's birth to heal, to bond, to do the things that families would like to do so that you can balance that care and work that is so essential for all of our families.
Yes. So one question that I have had about the effects of paid family leave, there's a subset, small, but I think substantial proportion of women who've just given birth who are suffering from depression. And I think in some demographics, particularly poor women, particularly young women, rates of postnatal depression are, based on what I've seen, quite high. And I've also seen research that for an infant to be spending most of the time with a depressed mother is very detrimental to development, that being with a depressed mother is worse than not being with the mother at all. And that's a particular situation, so it doesn't need to inform the broader policy. But this has been a big concern for me, that when you're looking at the most vulnerable families and the most vulnerable babies, right, which I think arguably are those born to very low income single mothers who are young, then what? The idea that a depressed mother has to go back to work for 2 weeks after she's given birth seems barbaric. But that doesn't mean that it's going to further the development of the baby to be spending additional time at that particular point with that mother. What are your thoughts on that?
Well, I think it is really important that we do our very best to identify these mothers as soon as possible, because depression in the postnatal period is pervasive. It's linked to maternal mortality, it's linked to infant mortality, and to negative impacts on children's development. And it's treatable. So we know that there are things that we can do. There's a range of behavioral health issues. Sometimes it co-occurs with things like substance misuse or part of family violence, or other things might be present. So not saying it's simple, but the paid family leave is one of these policies. But I think for everything, we need to really be thinking about beginning prenatally, identifying women who might be at high risk for any sort of additional stressors that would impair their ability to bond with their child or affect their children's development, and get them into some of the programs that we know can really support women beginning prenatally. There are several home visiting programs that do this. Community-based doula programs can be a very supportive environment for families, and or if it's obviously very serious, into the actual treatment programs that are needed. And that same goes for the postnatal period too. We wait 6 weeks before most women are told to come back to check on their health postpartum. But there's a lot of states that are checking on the mom's mental health when the baby is going for the baby's checkup, because we know how important the mom's mental health to the child's development is. So there are many states that are allowing Medicaid to actually pay for that screen. Some states are actually requiring that doctors do that screen. Some are recommending, some are allowing. And so now you have the majority of moms who will bring their baby. They want to see that their baby is growing and is healthy, and they will go at 2 weeks and 1 month and 2 months, et cetera. And that gives us more times to check in on that family as a whole so that we know that both the mom and baby are healthy, and then get them to the resources that they need. There's also a lot of programs, home visiting and early Head Start programs that have evidence of effectiveness, that if we could get the moms into those programs just as soon as possible, that has someone coming in to check on her regularly. Maybe there's a place for the child to be able to go if it is an early Head Start program and a center-based. And there are some of our programs on our roadmap, Family Connect's Healthy Steps are 2 examples that do these screens in the child's pediatric visit or in the hospital before the mom even leaves. They say, can I come and visit you in 3 weeks and check in on you? They don't offer services to families who don't need them. They identify what the needs are of families and connect them to those services. So I agree with you that there's so important that we really try to identify this and get these families the treatment that they need. But there are a lot of avenues. And like you said, these kind of broader based family supports like paid family leave, we shouldn't not do them because there might be a group of moms who need intensive support. And for the most part, they're really trying to minimize the stressors that moms are facing right after having a baby, which can be so huge if you're trying to do it all.
So you mentioned doulas, and I think that's a strategy that you've just added to the roadmap this year, right? Can you explain what is a doula and what role they play and what you found in terms of evidence for that as an effective strategy that states can implement?
Well, doulas have been around for as long as babies have been being born, but they're really to think of them as a support structure for the mom. And historically in this country, especially among Black families, and especially during the time of slavery, doulas were a really important source of support because a lot of Black families, especially when they were enslaved, of course, didn't have access to any sort of medical treatment that they could go to. So they had their babies at home and with the support of a community member. And over time, we kind of lost that approach. And more recently, states have really been trying to tackle this issue of maternal mortality, maternal morbidity, that is more than twice as large in the Black community as it is in the white community. And so there's been a lot of focus on these initiatives that are called community-based doulas. And what that does is a trained person who understands both the kind of development of the whole pregnancy, as well as how to provide supports for that mom and how to communicate with the kind of medical establishment. They work sometimes as a liaison, as a voice. Sometimes very hard to advocate for yourself when you're pregnant and to ask the right questions or to understand all the information that's coming at you. And so in many programs, they start during the prenatal period. They're there during labor and delivery, and then they will often stay with the mom, making these sorts of visits pretty regularly for 6 and sometimes even 12 months postpartum. And they are not a medical professional in the same way that a midwife is trained, or a nurse midwife or a gynecologist or obstetrician, but they do come from the community. They understand the moms that they're working with, and they understand what is really important for a developing fetus and newborn. And now there are over a dozen states that are using Medicaid to allow Medicaid to reimburse doulas for some of their support. One of the most interesting things that we learned was that on average, doulas spend about 74 hours with the mom, beginning prenatally through labor and delivery and postnatally, as compared to about 2.5 hours total for the obstetrician during that whole period of time. Plus, with labor and delivery, then it's 5.5 hours total. But you can just see there's a very big difference in the scale. And so it's really that one-on-one sense of support that women get. And there were 3 rigorous randomized controlled trials that were done for women who received doulas. 2 were done in different places in Illinois, and 1 was done in upstate New York. And they found pretty significant impacts of having a doula, not only on birth outcomes, but also on issues of depression and feelings of social support and on parenting behaviors and so forth. So we've added it to the roadmap. That's our goal, is to continue to expand the evidence base and add things as the evidence tells us, that informs that this is something that's effective. And so this was the first year that we were able to add that to the roadmap. I do think it's important that states don't think, okay, we've done doulas, so we've done birth equity, or we have ended the issue of maternal mortality. It's part of this whole system of care to make it so that kids are healthy and parents are able to provide and care for their children. But it really, I think, is an important part of that system.
So the roadmap that you've just released will provide links so that people can check it out for themselves. It's comprehensive. I'm hoping that our audience checks it out. It's just a tremendous resource. So this year, you've laid out, as I said, 4 policy goals and 8 strategies. Among those 12 policies and strategies, are you able to say which you are most excited about? You love all your children? Do you love them all equally?
You love all your children equally, but maybe in different ways and for different reasons. We are not advocates. I'm an educator. And what we've kind of laid it out to be is a choose your own adventure for state policy leaders, that we have told them, and by laying out 20 different outcome measures, kind of a guide to where they're doing well on some of the policy goals and where they're not doing as well, and then align the policies that could help them to meet the goal that they may have. And so what I can tell you is that if you want to make it so that families with young children are more likely to work and be able to be self-sufficient, well, there's a handful of policies that do that. Effective child care subsidies, paid family leave programs, higher minimum wages, earned income tax credits. Those all have a very strong evidence base, helping support families as they work and raise their children. If you want to improve birth outcomes, well, we have a set of policies that are aligned to do that, including a state's minimum wage, Medicaid, and centering pregnancy or group prenatal care, and community-based doulas, for instance. If one of your goals is that you improve parenting outcomes, well, there are a host of policies that will do that. So I don't necessarily have a favorite policy, but there are some that are somewhat unexpected. I did not understand how strong the link between minimum wage policies are and birth outcomes. There are some that do better at reducing disparities between race ethnic groups or between socioeconomic statuses. But it really does start with what your goals are. And we're not here to tell you what those are. We assume that you share the goal that all children should thrive from the start, that that's kind of a universal goal. And again, we're not neutral to that, but we are neutral to the policies that will help to meet that goal. I use a bad joke all the time that if it was underwater basket weaving was the state level policy that made it so that kids thrive, that would be on the roadmap. But the evidence for that doesn't seem to be strong at this point, so it's not there yet. And I think another important thing, I learned a couple of lessons that are really key takeaways. One, there is no magic bullet. it does require a combination of these broad-based economic and family supports and targeted interventions that really meet the specific needs of families to create that system of support or those conditions in which children can thrive. So too often, we have folks, it's just about childcare, or it's just about paid family leave, or it's just about home visiting. And I understand how policy works. We have to prioritize. But the truth is that families don't operate in isolation. They have needs across the board. And when we can identify what those are and get them the targeted services and benefits that will help them, that's important. I think one other key takeaway, which is sometimes a little bit hard in the policy world, is that when we're talking about infants and toddlers, they do not exist outside of their family unit. There's nothing that we can do to just help them without helping their families. We've tried that with our K-12 system. If you ask me, I'm a former teacher, and we send kids to school and we act like the schools can fix everything. And the truth is, the schools can't do everything, right? It really is about the families in which the children are thriving, the communities in which the children are living. And so the same goes for infants and toddlers, but even, times a million, that you have to care for the caregivers so that they can do the job of caring for their kids. They're best suited to do it. The government is not best suited to do this. But that means that they have to be able to work and provide for their children. It means that they're going to need childcare and adequate nutrition and so forth. So I think that there was some folks maybe early on who hoped that we could identify these kind of child-specific policies. What can we do to help the kids? And it has to be in combination of helping their parents as well.
That makes perfect sense. Right. In this area, early childhood policy and family policy are not separable.
That's right. That's right.
So, Cynthia, finally, you've been working in the field of child and family policy for a long time. I'm wondering what you see as the biggest progress over the past couple of decades and where you're seeing the biggest obstacles or gaps to improving the well-being of young children and their families.
I think perhaps the biggest kind of win that we've had is a recognition that it takes a combination of kind of family and economic supports, health interventions, as well as early learning programs to support kids in these earliest years. And that remains one of our biggest challenges, is that the early learning folks are kind of in one silo, the maternal and child health folks are in another silo, and the fatherhood folks are way down the field. And then the economic folks who are about tax credits and paid leave are often not talking with those folks either. And it's not out of bad will, it's out of the way that we've structured how we push policies forward, but that we know what it is that kids need. And we have seen states, in the 4 years that we've been here, we have seen 21 states basically adopt at least one of these policies. So we are really excited to see the kind of progress that states are making. But this kind of not even a three-legged stool, because it doesn't feel like we're all holding each other up. We really do need to see that what we need is to center the family and to think about what it is that the family needs in order to really make the impacts that are necessary for families to thrive. I think that's probably my greatest hope, is that we kind of come together more collectively and see this as a set of resources that are available, and that families have maybe a smorgasbord, if you will, to choose from. I've been around long enough to see that when we rolled out our home visiting programs, for instance, I was talking to one community about how they were recruiting families for their home visiting programs. And they were serving 3 and 4-year-olds in the program. And they went to the Walmart parking lot and they saw families with young kids that looked like they were 3 or 4 and said, "I bet you need our program," and went up to that family and tried to recruit them. And they don't do that anymore. But that's the exact wrong way of thinking about how to serve families, right? That we have good screening tools. We have doctors that families see. We have childcare teachers that are very trusted among families. We have folks who can be well trained to understand what the family's needs are and connect them to those needs instead of providing them with whatever it is that we happen to have available. And I think that more targeted interventions will make a bigger difference for families.
Cynthia, thank you for spending so much time. This has been wonderful. If people would like to learn more about your work, where should they go?
Well, we have a brand new website, actually, at pn3policy.org. And I'm also very easy to find at Vanderbilt University. But pn3policy.org, we also are on Twitter and LinkedIn, and we have a listserv, and our website has tons of resources. And we really do exist to be a resource for states. I am a researcher, but I've made the career decision to not just work to produce the new stuff, but to really translate what we know so that folks can have the best information available to make informed decisions. So reach out to me and ask me for any help that I can provide, because that really is what I'm here for.
Thank you so much, Cynthia.
Well, thank you so much. I really appreciate the opportunity to talk with you today.
Thanks so much to Dr. Osborne for taking the time for this fascinating conversation. And thank you for joining us today. Please subscribe to the podcast so you never miss an episode. Check out our work at ccfp.org and follow us on Twitter at _CCFP and at KB Stevens. We'll see you on the next episode of Early Matters.
You've been listening to Early Matters, the podcast on the science and policy of early childhood, produced by the Center on Child and Family Policy.